it's a pleasure to be here. You're truly an amazing advocacy group. Really, you're doing great work. So I'm currently at Thomas Jefferson University Hospital. I'm based out of Center City, and most of my clinical practice is with prostate cancer or other urologic malignancies, and about 95% of it is with the MRI LINAC. So we're going to talk a little bit about getting to yes. I mean, how many people in the audience here that are survivors have been told by their physicians or consultants that, oh, we can't do that? Because I know I see patients all the time, I'm sorry, we don't do that, or, you know, we don't, it's not what we do. So we're going to talk a little bit about how we try to push the envelope and talk about re-irradiation after many different types of treatment, whether it's surgery and recurrence or prostate seeds or IMRT or other older treatments, or even stereotactic things like CyberKnife or cryotherapy, how we're finding ways to treat that with the Meridian ViewRay MR LINAC. Okay, so getting to yes. Well, that's always tried to be my motto. We really need to get to yes and not really look at, no, we can't do that, let's just find a way. Okay, so just a funny little video of people like get...
Yes.
Yeah.
Yes.
Yeah.
Yes.
Yeah.
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 So that's our motto. Just find a way to get it. It's always good to have a little levity. And what we don't want is people saying no. So with the Meridian and smart adaptive therapy, we can really target specific organs and, even more important, stay away from all critical structures. You know, it's kind of like bringing your car for repair and telling the mechanic that he has to keep the engine running while he does the repairs. Well, the MR LINAC basically, as the body's moving, the prostate moves. It's very mobile, and it's moving because of gas in the rectum and bladder filling. So the Meridian with adaptive therapy helps us to account for that movement, and you can see in that video the prostate, which is outlined in red, how it's inside the target, and the beam will be on when it's in the target, and the beam will be off when it moves outside the target. So the critical structures are protected, specifically being the rectum and the bladder. So you've previously heard, you may have been told by other physicians, oh, well, you're going to get proctitis, rectal irritation, and bleeding. Well, this is why these risks now are as close to zero as we can get. So you can see it is that's why we call it smart, way smarter than me. And we do it with stereotactic treatment, which is usually 5 fractions. So on my right side, the conventional radiation, or even conventional IMRT, we really can't account for that movement. So we're using Meridian now in many sites. We use it in prostate cancer. We use it in oligomets. So what's oligomets? You know, with the PSMA screening, which we use all the time, PSMA imaging, we're finding small little metastases in lymph nodes or bone, and we're curing those patients. We're shooting for cure, and we treat them concurrently while we're treating the prostate if there's 5 or less lesions. We're doing this more and more and more. We use it in other sites like the liver, the lung. Just recently I ended up treating a gentleman with renal cell cancer with a pulmonary metastasis in his upper lobe, and there's no better way to be able to account for that breathing movement and treat the least amount of lung tissue. So, everything is based on data, and it's like, you know, remember the old commercial, well, where's the beef? Well, this is the beef. So the Mirage trial, what incredibly smart docs. Dr. Kishim, this is just the beginning of the data he's showing that showed such a significant advantage to using the ViewRay MR LINAC as compared to CT-guided linear accelerators for stereotactic treatment. There was a 60% reduction in urologic side effects, frequency, slow stream, and there was no grade 2 or higher GI toxicity, and it was so significant that they actually had to close the trial early, ethically, because it was just that significant. That's incredible. So again, they published the paper in JAMA Oncology, and again, the morbidity was so significantly lower, they closed the trial, and we're proud to be able to offer this type of treatment at Jefferson. So in the trial, basically looking at GI and GU morbidity, you can see in the darker green how low the side effects were for the GI and GU malignancy. So, why is that? Well, you can see on the video screen here that the prostate is moving, and look how it's moving during respirations, with bowel gas, with bladder filling. And as the red target moves outside of the volume, the beam is off. That's why there's almost no rectal morbidity. And at the same time, with the bladder, we're treating such tight margins of 3 millimeters or 2 millimeters or less. The beam's off, so again, the side effects are so little. So we're actually accounting in real time. Can't do that with protons. Protons are great, but not for movable structures. Okay. So patient-assisted innovation, what does that mean? Well, the patient's able to see that screen. Now, this is treatment. We treat lymph nodes from the prostate in the belly all the time. Many men may have castrate-resistant prostate cancer, and we're treating in the retroperitoneum, even retreating. So on the screen, it allows us basically to account for that movement, and the patient can see with their breathing when it's off and on. Here, we're one of the few in the country. Just hold that for a second. Can we hold the slide for a second? Can you just go back one, if you can? That's great. So we're one of the first in the country that's able to treat post-prostatectomy treatment fields with recurrences. So if a patient has an elevation of their PSA, we do a PET scan, and we can visualize where it is and treat. Now, this is a very interesting gentleman. It really goes to getting to yes. This gentleman had 4 sites, 4 targets, 2 bone targets, lymph node and prostate. And you can see here how, where it's around the rectum, here, how it was hot. So I put in a barogel spacer, a gelatinous spacer, which is made out of hyaluronic acid to protect the rest of the rectum. And with the view ray, we were able to treat him in 5 fractions, and this was a retreatment. And I've already seen him in follow-up, and he's had 0 morbidity. So quality of life is really so important. If we follow this patient here, I don't know if the video should be running, but this patient is being treated while bowel gas is moving down the rectum and while the bladder is filling. And if this patient was treated with protons, obviously the high dose area would be in the rectum, not the prostate, because of that particular moving. So just watch here. This is really what I like to call Meridian magic. It's just really the beauty of the MR linear accelerator. As you watch the rectum, you'll see the bowel gas going through the rectum and how it pushes the prostate. Are you able to play that video? Okay, guess not. So this is one patient that we treated for recurrence. 83-year-old gentleman, treated with IMRT 2005, presented with a recurrent PSA of 5.5, and he had biopsy-proven disease in 3 cores. We used a PET scan to delineate the target in the left apex. As you can see, it lit up there in multiple colors. And we treated just that area on the ViewRay MR Linac. You can see that I got a really good spacer underneath the prostate with the barogel hyaluronic acid spacer. And I've already seen him twice in follow-up, and his PSA went from 5.5 to 0.2 on first follow-up, and he has no morbidity. Second gentleman, very interesting, 71 years of age, treated with CyberKnife in 2013. Then he was treated with cryo, whole gland in 2021. Finally, again, had a PSA recurrence of 5.0, and he's found to have grade group 4 disease, high-risk disease, in that area of light up on the PSMA PET in the right transitional zone. So we treated, you can see on the right side, that target. It was just partial glands, and we did get a spacer underneath that. And I've also seen him in follow-up, and he had zero morbidity, and his PSA is coming down. 75-year-old gentleman, active skier, skis in the Alps most of his life since he's 65. He had brachytherapy, low-dose rate brachytherapy, 2009. He had salvage therapy in 2000, right after that with brachytherapy, high-dose rate and hypothermia, 2019, and presented to us with a PSA of 5.1. And you can see on the right side is his PET scan with the area of uptake, and we treated partial glands, and I've also seen him twice in follow-up, and his PSA is less than 0.5, and he's had zero morbidity, and he's still skiing. So we really do have a salvage treatment that works very well. We couldn't do this without the MRI Linac because of interactive motion and adaptive therapy. Very interesting situation. So this is a 73-year-old retired federal officer who was treated with IMRT, followed by salvage cryo. In 2013, his PSA was bumping up to 4.95, and he recurred in the seminal vesicles. You can see the light up, the two little rabbit ears. So we treated those only. As you can see it in the target. I got a very, very thick barrigel spacer underneath it, and then the red target, which is those little rabbit ears, is what we treated with, again, always stereotactic and 5 fraction, and I just spoke with him. He's in Florida, just enjoying the sun, and no morbidity. So, very interesting case of a 73-year-old gentleman with multiply recurrent prostate cancer, initial diagnosis 2003, and he had unfavorable intermediate disease, Gleason 4+3, and he had salvage radiation to his prostate bed in 2004 to almost 65 gray. He had a rising PSA, and he had a PSMA PET, which really just shows uptake right here. Kind of hard to see. There's a little blush just above the rectum. So he's already had radiation. And you know, it's hard to commit someone to hormonal therapy, as you well know, long term. It's if we can stay away from the morbidity and use it farther down the line if we need it, that's great. So this gentleman, we treated really just that target. I was able to get a spacer in underneath that area, and we treated just what's outlined in the red on the with the MR Linac and sculpting that hyaluronic acid spacer just underneath that side. And he completed the 5 fraction treatment and has done really very well. So it's really a whole new frontier for us. This gentleman was treated with a laser, and he had positive bony metastases. Was started on hormonal therapy and presented to us with a solitary recurrence in the right seminal vesicle, and you can see on his PET scan that there's uptake on the right side, that little tail there. And he also had uptake in one single area on the PET scan in his thoracic spine. So on the MR Linac, we treated, I was able to get a spacer underneath that, and we treated it with 5 fraction stereotactic treatment on the ViewRay. And then we're going to be treating this single area on the rib at about T10 with 3 fraction stereotactic treatment as well on the MR Linac. And he's working every day as a federal officer in the airports in Philadelphia, so he's very active and doing very well. Post-op radiation after surgery for recurrences, usually it's 34, 36, 38, 39 fractions, Monday through Friday, 5 days a week, and we treat not only the prostate bed, but up to the areas where the seminal vesicles were. And it's tiring, and the morbidity is lots of urinary frequency. But now, if we can define the area of the target, if someone was treated many years ago and their PSMA scan only shows a single target, it doesn't make sense to treat the whole prostate bed. So we're treating these patients just to the area of uptake. And you can see here, and I was able to get a really long spacer underneath it, and those patients are treated on the Meridian MR Linac with only 5 fractions stereotactic, and their PSAs are undetectable, and their morbidity is close to 0, if not 0. So we go all over the body with oligometastasis. This is a very interesting patient. I don't know if you can put the video on. This gentleman had spinal metastases previously treated, and he also had an adrenal metastasis on the left side. So we were able to retreat the spine and treat the adrenal metastasis with adaptive therapy on the ViewRay at the same time. That video is supposed to be moving on the farthest one to the right, but you'll see actually how organs move. I don't know, can you get that moving? I guess not. Yeah. Okay. So that's basically it as far as talking. I'm sorry some of the videos didn't work, but that's, as far as retreating using the MRI Meridian ViewRay, we've been able to really reach new frontiers in the treatment of prostate cancer in retreating, perhaps sparing using androgen deprivation therapy for a later point in time, being able to target areas where they previously couldn't be targeted before with highly efficient and targeted stereotactic radiation. And with the ViewRay Meridian machine, as well as placing a spacer, the morbidity is very, very, very low. And as you can see in the Mirage trial, this is a whole new frontier for us for treating prostate cancer, localized and metastatic. Can I answer any questions? So we use it all the time. Great question. We use it all the time for prostate cancer, for not only localized to the prostate and seminal vesicles, but we're also using it. We have a protocol where when we want to treat the prophylax the nodes as well, we're actually treating them on the MR Linac in 5 fractions. And because we can keep such a tight margin and adapt, because you're at multiple levels, because we can adapt for a bowel movement, rectum, everything's in a different place every single day, every moment. We're able to do it in 5 fractions over a period of about 10 days. So that's a great point. And those patients, that's what the Mirage trial was, and that's why they closed the trial, because the results were so much better. Yes, sir? So it's usually stereotactic treatment, which is 5 treatments. And so we do it every other day, no weekends. No one wants to come in on a weekend. So it's usually 5 treatments over about 10 days. The treatments, if it's just localized to one area on the machine, they can take about an hour, because on the MR linear accelerator, every time is a new time. With conventional radiation, we do the planning and we use the planning. You come in, you get your treatment, and leave. But with adaptive therapy, each time is a new time. So we're recontouring and seeing how the plan works on what the patient looks like that day. And we're adjusting for where the bowel is, how full the bladder is, and replanning on the fly. So it takes a little bit longer, but it's that much more precise.
curious about if you know how widely available this is at other centers.
Right. So I believe there's a little over 50 MR, at least ViewRay. I don't know about it. There's one other company in the world, but it's growing precipitously. More and more centers are adding. I think there's 52 or 53 at centers of excellence. And I think you will see that it's going to be growing more and more because of the precision, and we use it all over the body.
I'll ask a question.
Yes.
We have questions all the time about coverage.
Right.
I know you're not an insurance
Right.
claims specialist, but
Right. So it's paid for like radiation is paid for, particularly stereotactic radiation. There's, at times the way it's billed, it's like a new plan every single time. And again, those are what the insurance people work out for. It always seems like when people have Medicare, it's the easiest, but it definitely is reimbursed for. Yeah.
any other questions?
So basically the side effects, what we look at are side effects for, if it's in prostate cancer, the rectum and the bladder. And with placement of the spacer, for an upfront prostate, someone never treated before, usually about a week after, patients may have a little bit of slowing of their stream, which lasts for a week or two. Usually we prophylax them on things like Flomax or alpha blockers. It's very rare to have rectal side effects, almost zero, because of the spacer and how precise the treatment is. Now, it depends on where we're using it. Right now, I'm treating a gentleman who has no kidney on the right side because of kidney cancer, and he's had cryotherapy twice to the lower pole of the left kidney for kidney cancer, and he has a mass in the upper pole on the left side. So to be able to spare him dialysis, to remove that, we're treating that with the MRI Linac at this point in time, and we're sparing almost the entire lower pole. So then we look at bowel side effects, but it's so precise within 2 millimeters margin, and we can account for that breathing every day, that the side effects are very, very little. I mean, there's no reason people can't work, play tennis, play golf, whatever they're ordinarily doing in their lifestyle. We don't see incontinence, and erectile dysfunction with the MR accelerator is well less than 10%. And I think as they update the Mirage trial, you're going to see how low it really is. That's really incredible. Yes, sir.
Do you have anything significant coming down the pipeline?
Sure.
Is there anything significantly new coming down the pipeline?
Right. So, yes. So with the MR linear accelerators, there's always software upgrades, and it's allowing us to speed up the treatment, where anywhere from the brain down to the prostate and below, the treatments that ordinarily took 45 minutes to an hour and 15 minutes are now taking less than a half hour. And that's great because the patient's on the table. And that's one thing. And the second thing, of course, as you saw there, the interactive treatment where the patient can see their organ, and they can see how they take a slight breath and it brings it within that sphere of what we're treating. And those, it's really, the patient is really a part of the treatment as well, and enables us to be very, very, very precise and speed up the treatment. So just lots of things like that. Between that and with molecular imaging like PSMA, it's really helping us to target areas we never saw before. And of course, retreatment is really very revolutionary, and there aren't a lot of centers that do that. Okay, well, it's been a pleasure. Thank you very much.